What I want to talk about specifically is how you utilize these medications for opioid use disorder in the setting of pregnancy. And to do that, I want to use a patient. And this is Kayla. This is a real patient of mine. It's not a real name. In adolescence, this is a patient who had a family history of addiction. And this is going to be really common to the vast majority of patients who end up with a substance use disorder in your clinic. Some moderate early life trauma, meaning that she had a sexual assault when she was in early high school. She had a verbally abusive and sometimes physically abusive stepfather, but not severe. So she would be on the moderate to higher scale for the adverse childhood events. And in fact, in our clinic, we actually stopped screening for ACEs because everybody was severe, and it was a wasted screen. We just assumed that everybody had significant early life trauma and created that trauma-informed care system around that. And that's just how we approached everyone. And I think that ultimately that's the only way that we can approach patients who have addiction ultimately, because I find very few that I can name literally 2 of the hundreds I've seen that have 0 early life trauma. And that's for males and females. So at the end of the day, it's a ubiquitous precursor to this. Early substance use, most of the time the early substance use in this population is specifically focused on really trying to tamp down a lot of those emotions and feelings associated with that early life trauma, that depression or anxiety or those things that sometimes crop up really rapidly in a patient who's had that trauma. And incidentally, she had had an elective pregnancy termination at 17, and after that felt very disconnected from her friends, even though they were the ones who kind of pushed her to do this, and then she just kind of involuted from that, and then left high school, did finish her GED, and was working. And then in her early adulthood, after she'd had a car accident, she'd hurt her back, was placed on opioids, had been maintained on that, then had muscle spasm and anxiety, so therefore she was placed on benzodiazepines along with it, and utilized marijuana intermittently. Typically, when she had overused her benzodiazepines and ran out, she would utilize that to bridge her to her next pathway. Her anxiety, as we could expect, was poorly controlled for a number of reasons, and she had both physical dependence and addiction to the benzodiazepines. So you can take benzodiazepines daily for up to 6 months and still not have a true physical dependence to those, and you can stop them and be fine. However, after 6 months, you can have a really profound high-risk withdrawal, as we talked about earlier. And now she's pregnant. She has no social support. And we found her because she came in with a friend of hers who had been referred to the clinic as the support person for that. And when I'm doing the interview of her friend, I noticed her body language as I was asking these questions and doing some motivational interviewing stuff. And then I, halfway through, pivoted over to her and said, why don't we get you signed up? And in doing so, because she didn't say anything, she just sat there, but you could easily tell that when I was talking about, that we can get you stable, we can make you feel better, all of these things, she just kind of showed that. And so this is who I want to talk about. So when I talk about, so what are we going to do for somebody like Kayla? If we look at the MATs that are available, there are really 3 FDA-approved medications that we use for opioid use disorder in general. One is buprenorphine, and that comes in a bunch of different forms now. So it's often known as Suboxone, but the base medication is buprenorphine. And then when you add naloxone, which is really inert when you take it as prescribed, what that does is it decreases the diversion of the medication. So when you see naloxone, which is Narcan, remember the thing that wakes people up if they accidentally overdose? This is a medication that was placed in there in a 4-to-1 ratio so that if they wanted to melt it or dissolve it and inject it, that what would happen from that is they would be able to either not get high from it or actually have a small amount of withdrawal. Generally speaking, I have found clinically that you don't really have withdrawal if they do it, but it does decrease the effect and basically stops the effect of the medication from causing intoxication. So we have different forms of that. So you have Suboxone, which everybody has heard of. It was the first one that's out. That now is a strip. It goes under the tongue, and that dissolves in about 3 to 5 minutes. The generic is a pill. This is the original version of this that goes under the tongue and dissolves in like 13 minutes. I mean, so when we say we're just going to use the generic, we have some real clinical implications to that because it takes forever. So try putting a Tic Tac under your tongue and holding it there without swallowing for 13 minutes. Because that's the instruction that we have to give the patient in order to fully get all of the medicine in. Because if you swallow, it doesn't get absorbed because buprenorphine has very poor bioavailability, which is why it's dissolved rather than ingested. And then we have Zubsolv, which is another one that goes under the tongue. It's an oral dissolvable tablet, so it's different than the film. And that one is a little bit like ondansetron, so it's like a Zofran tab. So it dissolves under the tongue. Patients say that it has more of a minty taste than the orange fire that they describe from the Suboxone. And then we have Bunavail, which is the same ratio, 4:1, but goes on the inside of the cheek, and then that also dissolves. Now, each one of those doesn't have the same amount of buprenorphine. It's because they have different bioavailabilities. So the Bunavail has the smallest amount of buprenorphine in it, but it gets the same amount into the system as the larger dose of the Suboxone. So when we look at the doses and we connect what's equivalent, you'll notice that Suboxone has the highest dose, Zubsolv a little bit lower, Bunavail even lower than that. But the brain sees the exact same dose. It's just how it's delivered to the body. When we look at the other things, we have Probufene, which is an implantable version of buprenorphine, and that lasts for 6 months, and it can get up to 8 milligrams equivalent daily dosing for that one. Then we also have now an injectable version of buprenorphine, which lasts for 30 days, and it gets injected into the belly, and you get a stable dose of that. So there are a lot of different ways to get this medication. During pregnancy, however, we have some issues. The longer acting ones, plus minus, but sometimes if you get into some trouble in the pregnancy, anesthesiologists are not as familiar with this medication and get frustrated when we try to use it, despite the fact that we have successfully delivered three babies through C-section with only buprenorphine. So it is a good pain medication as well, and it can be done, but it's not there yet for prime time and utilization for that. So sometimes you can run into some of those issues. Methadone. So buprenorphine is generally dosed once to twice a day. Once generally is fine. As you get pregnant, you don't chew it up faster, so you don't need to split dose it like we have to do with methadone. And the average dose for somebody who's stable is between 8 and 12 milligrams daily. So if you have a provider who writes for 32 milligrams for everybody, that provider needs to be re-educated and evaluated for safety. These are just important pieces to think about. Average starting dose that shows that it does the best is about 16. I've had patients on high dose for short amounts of time to stabilize some other issues, but generally speaking, anybody on higher than that, you would want to look to get them down within 30 days. Methadone. Methadone is dosed daily, highly federally regulated, meaning they have to go and get treated daily, at least a minimum of 90 days, but most people longer than that before they can get any take-home doses, which is good and bad. So I don't know if methadone has better outcomes because of the medication or it has better outcomes because of the way in which it's delivered. So if you have to go somewhere every single day and be evaluated and people can see that body language of maybe you're not looking great today, let's pull you aside and have a conversation, I think the methodology of delivery is probably what makes methadone consistently more favorable. The problem with that is you have to have someone who gets them to the clinic every single day, and that's a real problem in rural America. Now, it's an easily circumventable problem with remote dosing capability, but that's a whole other pathway. The normal dose of methadone that you want to stabilize out for an average person, this is not pregnant patient, but just a standard patient, is between 90 and 120 milligrams. You're not even considered to have had a therapeutic trial until you've been above and consistently on 60 milligrams. So that sounds like a lot, but the body creates the tolerances in the way in which we talked about earlier in the cellular and neurological system. And so when we do that, you have to get to a steady state dose that pushes down craving. So what do these two medications do? Well, they stabilize dopamine. Remember I talked about how dopamine is depleted in the vast majority of these patients. Some of them because the structure has actually been injured and they just can't produce it. Some because they had a predisposition which made them make less dopamine, and then they need to stabilize that up. As you get dopamine to a normal level, then they can actually engage in the behavioral therapeutics. Because without an appropriate amount of dopamine, you can't onboard emotional memory. Right? So what is emotional memory? Therapy. So if you don't have someone whose dopamine is stabilized, then when you put them in therapy, no matter how intense it is, what they hear is rah, 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 rah. Right? They're getting nothing from it. So this is a real issue that we have to think about, and what patients on these medications feel is normal. Right? The problem we find with methadone is the time in which we have their appointments set up is about an hour and a half after they initially dose. So if you dose at 8 a.m. and you have an OBGYN appointment at 9:30, that's the peak time of dose. So they're going to be kind of nodding out. especially if they're pregnant, because you get this peak dose, but they chew it up fast after that. And so they're actually, in many cases, even in a little bit of withdrawal in the morning before they next dose. So sometimes they'll increase the dose so that they can cover that withdrawal phase. But what that does is it makes that peak dose such that they're a little bit somnolent at that time. And so they'll be like the kind of nodding out. So what we want to do in those cases is not dose them at a higher dose one time a day, but split dose them so that we can maintain that stability of decreasing craving and make them feel dopamine normal, but at that point also give them the capability to spread out the dose so they don't have withdrawal in the morning. So those are some practical things. Now Trexone is a medication that blocks opioid receptors, is used in patients who make natural dopamine, meaning they're motivated. So if you have a really motivated client, not pregnant, but a really motivated patient or client that comes in, this is a good medication for that. I've used a lot of it. It has a place in there. It's just not first-line therapy because it does require patients to make natural dopamine, which we can see as motivation. In pregnant patients, it's probably not actually dangerous for the fetus. We don't have any data to show that it causes harm to the fetus, but if you're blocking all of your opioid receptors and you need a crash section, that's going to hurt, because I now can't give you opioids, and it makes it somewhat difficult. So it becomes problematic in that setting. Probably not problematic with the fetus, but at the same time can create just some logistical issues if we need to do some things in the middle of pregnancy, second or third trimester. And if we look at this buprenorphine in a pregnant population, they're really motivated at that point in time. It's my favorite group of patients to treat. And if I ever went back full-time clinically, this is the only population I would see. I would literally just open a clinic dedicated to pregnant patients because they are a pleasure to work with and they're very motivated, and you do get to kind of stop that cycle when you do it. And you can get up to about 75% effective rates during pregnancy. So that's pretty amazing because we're not that good at anything else we do in medicine. And it's about that or a little higher for methadone. And again, I don't think it's the drug effect. I think it's the way that it's delivered. But again, I don't know that because they're not going to do randomized controlled side-by-side trials of daily dose of buprenorphine because patients won't tolerate that because they know they can just go get a prescription for it and have a little better lifestyle than having to every morning show up and get a dose. What about abstinence-based treatment? So if you look at overarching opioids, this is about 8% effective for opioid use disorder, 8 to 12% depending on which population you're talking about. But that means it's 92% ineffective. And if we had, here's a medication, can you imagine the informed consent for that if we actually did one? So we got this thing, right? So it really only works for 8%, but you might be one. You might be one of those. You might be that 0.8 out of 100, but it's going to be fine. You're going to be fine. And nobody would agree to that, and we shouldn't actually agree to that as a society, especially since we know that putting a patient on medication-assisted treatment decreases their mortality rate by 50%. I mean, we don't have anything else that does that. Cardioversion for VTAC is a 30% mortality decrease, right? There's somewhere in here, there is something on a wall that I could shock you with. And we allow the general public to have access to the thing that will shock you, because it has that benefit, and this has more of a mortality benefit. So it's really important to keep that in mind. And then the other piece is that, can we physiologically detox a patient who's pregnant without causing harm to the fetus? I would say the data says yes now. So, but the question that we have is, what are we treating? If the question is, can I, from a mathematical and medical sense, stably detox a mom without causing significant harm to the fetus, I think we have enough research now out of Tennessee to show that that is, yes, we can. The bigger question is, should we? Because now we're putting them back into that 8% category where I'm going to have a patient who's going to die or have a higher risk of overdose that requires reversal, which puts them into fluoride withdrawal, which puts them at higher term for preterm delivery. And definitely you get into that increased cycle of intoxication and withdrawal as compared to stabilizing someone who can now engage in behavioral health treatment, work on that trauma, have a plan set up, and be able to move through the stages of change that they need to, that when they leave, they're not like every other new parent and freaking out. Right? So I remember I'm an ER doctor, right? I'm trained in this. I've worked in pediatric hospitals. I still was like peeking in the door to make sure my kid's breathing. I mean, that's like the normal thing. I had like the creepy monitor that you can see him at night. I was like, is he moving? And I know the risk is super low, But even I, without all of these other things, worried about that. And so we have to really worry that if we have a mom who is not stable and feeling normal and has motivation and has a surrounding group with them, that heightened sense of alertness and worry can be really maladaptive. So this is an important thing to ask. What level of care? So there is no such thing as just, I'm going to send you to addiction treatment. There are ASAM levels of care. If you have a heart attack, or you have chest pain. So if somebody comes in and says, I have chest pain, we don't just send everybody to heart cath. That would be really creepy. You're 22 having a panic attack. I'm like, well, you got to get a heart cath because that's what we got. But we do this in addiction. So for everybody we see, if you're a hammer, everything's a nail. And if what you have is the ability to write for buprenorphine is an outpatient setting, then everybody gets buprenorphine in an outpatient setting. If you're a methadone clinic and that's all you do, then what you get is methadone on an outpatient basis. But patients need to be able to see, do I need outpatient treatment? Do I need intensive outpatient treatment, or level 2? Do I need to go to residential, meaning be in a place that's safer with a higher degree of clinical oversight? Do I need to be in really intensive residential, which has a lot of directed behavioral clinical oversight, and that's what we need a lot of times for early co-occurring disorders, for patients to be stable in that environment? Or do I have to send them all the way up to the addiction treatment version of an ICU, which is generally in a freestanding psychiatric hospital or in a psychiatric unit within a hospital? Level 4 care is not, I have a protocol in my hospital for treating the toxicological syndrome of withdrawal. That's not level 4 care. That's what I call medical student care, because it's a protocol. You put the order set in, and then it just magically happens. So if we put them at the right level of care, and we keep them on medication-assisted treatment, their risk of relapse is super low, especially during pregnancy. If we drop it off at the end, and we're like, they did great, baby's out of the belly, all right, now the bad stuff happens. Now this is the scary part. And so what we learned very early was that we re-intensified treatment 2 weeks prior to delivery, because we found an increased bump in use rates and relapse rates right up to that time when it's like super scary. What am I going to do? Oh my God, I have a human being in my belly. All of those things are happening. So we increased the number of times we saw them. We called them daily. So we had somebody would pick up the phone, how you doing, what's going on? So very intensive. And then afterwards, we were the first person they saw post-delivery. Not the pediatrician, not the obstetrician. They came and saw us. And the day that they saw us was the day they were discharged. So we saw them, we made sure that they had a plan in place, we had everything set up if we needed home-based care and implementation. We had set up family training while they were being seen, so we did parenting classes. We would talk about what to expect, what does irritability look like, because these kids are going to be a little more irritable. But if you prep the mom for this, it's okay. As long as you prep them to understand, you can understand that, look, if you need to let them cry for a few minutes without being there, that's okay. Do what I did, which is I put on my headphones and went in the other room, and I sat there for 10 minutes. I'm like, all right, okay, now I'm going to go back. And, there are practical things that you can teach them to do so they're not so overwhelmed, with these kids. So when we look at the benefits, we talked about all of these things, but these are the things that are all agreed upon with medication-assisted treatment. Stabilizing fetal levels of opioids reduces repeat prenatal withdrawal, which definitely changes the epigenetic changes that happen in the brain and the neuroscience issues that take place. Linking mothers to treatment definitely decreases the transmission of HIV and hepatitis to the newborn fetus, improving long-term health outcomes definitely for mother and baby, lower risk of neonatal abstinence syndrome, less severe neonatal abstinence, shorter treatment time, higher gestational age and weight. I mean, all of these things are what our goals are. And so why would we not do something that has all of these benefits in every study done? There's not one study that shows that, never mind, it didn't do any of that. Buprenorphine in pregnancy, the one caveat that I'll talk about is getting them on it. I've induced a lot of pregnant moms onto buprenorphine, and it can be really nerve-wracking the first time, but after we had done 4 or 5, and I did those in the inpatient, admitted setting while I'm sitting there at the bedside. They're on a monitor and a tokometer, and as I'm figuring this out. But by the end, we're doing home inductions. I mean, there are ways in which we can do this very safely as long as you train the mother, you have good contact with them, and they feel safe. And we started using, for those that had issues with any of those, just the OB triage, where we'd pop them in, get them there, and flip them over while they were there and get their first dose there. And then we'd see them the next day to make sure that everything looked good. And the right dose, and this is individually determined. I talked about the dosing algorithm. Remember in methadone, you may have to split dose this, that's okay. You may have to increase the dose of this, that's okay. Buprenorphine typically doesn't have to be increased, but there is one study that showed that serum levels of it did decrease in the 3rd trimester. It didn't seem to have a clinical impact on craving or outcomes, but we might find a physiologic issue where we may have to bump it 10 or 15%. Next. How are you going to see these patients? And I just want to say practically, early and often. We saw these patients minimum weekly, but a lot of times when we first saw them, we would see them every other day for the first couple of weeks. And some of those would just be nurse visits. They would just pop in. We wanted to eyeball them, see if they were okay, make sure we answered questions. They got calls most every day upon early intervention. We never went out more than every 2 weeks while they were pregnant. There's just no reason to try to extend out to a month or so. You just maintain that all the way through, and then we went back to weekly right after delivery. This is the plan that we used for our deliveries for patients when they came in. This was what we would write up. And we wrote a personalized plan for each patient based on their dose, but this was a general plan for delivery. And we knew if they were going to have an SVD that was planned or if they were going to have a C-section. If some people obviously revert to section, so we wanted to always have both of the pathways. And we had post-operative care. We even at the bottom of it put in neonatal risk score for their risk of neonatal abstinence syndrome so that the pediatricians would have something to look at as well. Because many times, it's not as much now, but the baby when born used to be fully disconnected from mom and be in 2 different worlds. I mean, it'd be very siloed treatment at that point where you have the pediatricians treating the baby, and then you have the obstetricians who may have known everything and totally on board with mom. Delivery went great, post-operative pain treatment is great, super happy. But then babies like having like not good stuff because they weren't aware of this, where it said that mom was also on marijuana, mom also had benzos if that was the case. And so we had to make sure that we connected those 2 pieces of the very different world in the hospital. Breastfeeding, yes, yes, and yes. I'll answer questions for it, but at the end of this, this is not a contraindication. This is a talk about it, talk about it, talk about it. Like I said, 95% of our moms, we were able to get them there. A lot of motivational interviewing, a lot of misperceptions out in the community that get relayed to these moms, so they just need to be given this information every single time. Withdrawal management, again, we talked about these earlier, but just be careful that benzodiazepine is pretty contraindicated, even though that data is probably really soft as far as true risk to the fetus, it's still there. And we talked about all of these different things. Again, 3 hours to 3 days after delivery. Nicotine, SSRIs, benzos, marijuana. I mean, those are the big ones that we're going to see prolonging it. If the mom still smokes nicotine, you are going to double the time frame that they have neonatal abstinence syndrome. It doesn't mean that we need to double the morphine that they have. We just need to make sure that we understand that it's going to be prolonged on purpose and possibly even more severe early. Mother study. The mother study basically says that buprenorphine decrease severity of NAS, decrease length of stay. Some European data that says that it doesn't decrease the neonatal abstinence syndrome percentage, but it still decreases that, the length of stay and severity, and increases head circumference and increases total birth weight and length of time in the belly. And then Kayla. Again, these are all the basic things that we would want to do for her that we talked about. It's important to think about this because these are not theoretical issues. These are real people that are having to go through this, and it can be really, really scary. And just make sure that you explain it. And if you have CPS that gets involved, Child Protective Services, you work with them. For the ones that were already involved or they had had a kid removed at some point, we would bring the CPS worker into the visits right up before delivery so everybody's on the same page. We would prepare a report for them, which became pretty standardized, so that we didn't have any of these kind of weird, I'm taking the baby things that caused that meltdown. Counseling, required for sure. Parenting, these are all just basic stuff that you got to do. And those are the references that we use for this.
Where did the statistic for 8% for effective for detox and abstinence-based treatment come from?
It came from an amalgamation. There are 3 books that have come out. It actually is also sitting on the SAMHSA website with the 7 different references. But 8 to 12%, depending on the population, for abstinence-based treatment for opioid use disorder. And again, we're specifically talking about opioid use disorder, which, by the way, is the easiest addiction to treat as compared to all of them. So that's where that came from.
And then Subutex versus Suboxone, can you talk about that terminology?
Yeah, so the Subutex is what's basically recommended for pregnant moms. Zero data to back that up, by the way. There's no harm data anywhere. And this is cohorts of thousands, hundreds of thousands of moms and births on buprenorphine in the European data set that showed no differences in birth outcomes, even minor birth outcomes. But Subutex has the highest diversion risk because you can crush it and you can inject it. And this is why, you know, we're not at the recommendation stage yet, but just think about it. The European data does not show that it increases the chances of risk, and naloxone by itself, if the medication is taken appropriately, does not cause withdrawal because it's barely, if at all, absorbed. And then even like we talked about earlier, if you misutilize it and inject it, it's such a small dose that it's just going to counteract the medication from causing intoxication and not acute withdrawal. But at this point, the ASAM guidelines, which I was a part of writing, and the ACOG instructions is to utilize Subutex.
The next one is a sort of a case study, but it brings up an important point that is probably an issue in other areas too. It relates a patient who is enrolled for a residential treatment program to help with her concurrent methamphetamine use, but the residential treatment program refused to administer the buprenorphine in spite of the fact she had a prescription and a note from the physician. Do you have any references that you can recommend for residential treatment programs that explains the data behind MAT during pregnancy directed towards their audience? Presumably it's an abstinence-only approach, so how do you?
Sure, no, I think we would first consult the malpractice literature. But I think from the other side of the literature, it's important to understand that a 50% reduction in death rate is amazing. And to stop somebody on it means you have to wean them and put somebody through a withdrawal that they didn't need to go through. And then what are you going to do when they get released? Because you can't stay in residential forever. Eventually, you have to go back into your environment. And the way that we stabilize a patient when they leave the inpatient space is to get them out. Now, the questions about can you decrease the dose, can you maintain it, those are things that haven't been fully answered in the literature, but stopping it offers absolutely no benefit when we know that maintaining somebody on it offers a significant number of benefits, which I showed on an earlier slide.
Right, so I think the conversation, as you say, is really, really critical.
Absolutely.
It helps. And then any best format for parenting education postpartum in the postpartum period? Groups, individual, therapy, what works best there?
Yeah, so we would bring our moms in and actually interact with their kids with them. So directed training and teaching becomes really important because just showing them a PowerPoint about how not to get angry at your kid doesn't really work. You have to show them those techniques of de-escalation. You have to show them the techniques of distraction in kids rather than expecting them to just understand what you say. So starting before delivery is always better because it also helps them to be a lot more relaxed at the time of delivery. So if you can, definitely prior. And there are some standardized training modules from the American Academy of Pediatrics about some of these parenting things. The biggest thing is to make sure that they understand that you have help and you have backup as a parent, and we have to provide that if they don't really have it, because I have a lot of my patients who were really on their own from a family standpoint or from a support standpoint, so we have to identify places for them to be able to go and call if they have those issues, and we would take some after-hours calls from the clinic that would be sometimes just parenting. I mean, and we would just flip a coin who would get those, who's on parenting call tonight, and that's fine, and we would do that, but they need that instruction because most of them ended up, because of that early life trauma, not in a great parenting situation to begin with, so they didn't have that behavior modeled early, and so we have to kind of onboard those changes.
Great, well, I'd like to again thank Dr. Waller for his great presentation.